I'd like to welcome you all to today's webinar topic, Implicit Bias and the Pursuit of Health Equity. My name is Gal Vang, and I am a Quality Improvement Specialist working in a dual role with Hennepin Health and Hennepin Health Care. This webinar is brought to you by the 6 managed care organizations called the Collaborative, which impacts the SNBC and the Menschel populations. This Diabetes Performance Improvement Project, also known as PIP for short, focuses on diabetes. All plans across the US serving Medicaid members are required to do a PIP. DHS collaborated with us to establish this as a priority project. All plans already have multiple initiatives in place to address the crisis. The PIP allows us to formalize this work and collaborate on interventions to bring them statewide. The project must be designed to improve quality of care and health outcomes, address a serious health condition, and improve member satisfaction, all with the goal to achieve significant improvement sustained over time. This PIP addresses all of these areas. I'd like to introduce Dr. Tali Vang. She is a licensed health psychologist and is currently the Director of Health Equity Education and the Welcome Services at Hennepin Healthcare. Dr. Vang has developed curriculums and trainings on a variety of topics around health equity and diversity, equity and inclusion, as well as implicit bias, impact of social rejection, disarming microaggressions, and navigating conversations on race. Dr. Vang also has strong clinical experience and deep knowledge on culturally informed case conceptualization and culturally responsive therapeutic approaches. It is my pleasure to introduce my colleague and today's speaker, Dr. Tali Vang.
Good afternoon, everyone. Hello. Thank you so much for spending your time with us this afternoon. I'm going to go ahead and share my screen with you all. Give me 1 second here. And as Gao has mentioned, I am going to be talking to you all today about implicit bias and the pursuit of health equity. And the way that this training is structured is such that we are going to start within ourselves, and then we're going to start to work outward and take a look more and more at society. Now, I do take a more behavioral health kind of perspective, and at the very end, I offer some evidence-based approaches to how we might be able to actually decrease our own biases. So I'm excited to be here with you all today. And I'd like to mention that whenever we talk about bias, implicit bias, anything that has to do with historically marginalized populations, there may be different emotions that come up for each and every one of us. Some of those emotions may be hurt, pain, right? Anger, frustration, guilt, any of those things might show up in you today. Please know that that is a part of the process. And I invite you to remain in process with all of us as we go through this training. I also invite you to lean into those emotions that can be intense and really work through them. So thank you for being here again. Why don't I go ahead and get us started? And in order for me to do that, one of the things that I really want to make sure that we start out with is actually this exercise. It's an activity. And so I ask that every one of you take a risk with me. And that risk is, if you don't mind closing your eyes, I'd like for you to I'm going to give it a minute for everyone to go ahead and close your eyes. Now, with your eyes closed, I'm going to walk you through an exercise. I'd like for you to tap into your imagination as much as possible. That means I'd like for you to pull in all of your different senses, right? Smell, taste, touch, hearing, all of these different senses. So hopefully everyone has their eyes closed. I want you to imagine in your mind's eye that today is your very first day as a resident. And today you get to observe the emergency department. You arrive at 5 a.m. sharp. You're dressed in black scrubs. Your body is feeling kind of tired, but you're ready to jump into the work. So you're instructed to stand back and observe for the day, because tomorrow you get to do light work. So as your preceptor is kind of talking to you, trying to orient you to the space and workflow, you notice nurses walking to and from rooms, providers making rounds, and rooms filled with patients. Now, some patients have some grimace in pain. You can see that. Some seem a little bit disoriented. You notice some patients have blood-stained sheets. There are different odors in the air, strong, intense smells. You hear the chattering of nurses and patients, the beeps from machines. You do your best to listen to what your supervisor or your preceptor is explaining to you. Suddenly, nurses start to rush towards a room. A young nurse walks by, grabs the physician standing close to you. You hear the young nurse tell the physician, "We have a GSW. Multiple shots to the abdomen, come quick." Your supervisor and the physician next to you urgently leaves towards the patient's location. You stand behind. Your heart is racing. GSW, gunshot wound. Multiple shots to the abdomen. Your adrenaline is pumping. You look over, you see a crowd formed by the entrance looking intensely with worry. You wonder if that is the victim's family, or if the victim will survive. Go ahead and open your eyes. Now, without answering, without saying out loud, I'd like for you to silently reflect on the next few questions I'm going to be asking you. First, how are you feeling in your body? Were you able to fully immerse yourself into that exercise? Do you notice your heart rate changing a little bit, or any tension in your body? What was the race of the gunshot wound patient? What was the gender? The age? What was the race of your preceptor, your supervisor? Their gender? Their age? What about the race of the physician being called, standing close to you? And their gender or age? And what of the racial composition of the nurses walking all around you in the emergency department? What were their gender or ages? As you reflect on these questions and think a little bit deeply about what images came up to you in your mind, I'm going to talk a little bit about how our brains do this. How do our brains make these stories up? How do our brains fill in these stories with images? Because all of these things and the ways that our brains function informs our bias, informs how we show up in the world, and impacts health outcomes. I'd like to talk a little bit about my positionality because our worldviews and how we've grown up, how the world has treated us, that shapes how we look back out into the world. It shapes how we see others, ourselves. And so my positionality is important here because everything that I share with you is really ultimately coming into me, right, as a person. And I am taking this information, I'm reflecting on this information, and I'm putting this information back out into the world. And you as a consumer are taking it from my perspective. So my positionality, personally, I identify as a cisgender woman. I use she, her pronouns. I also identify as a Hmong American refugee. I was born in a refugee camp in Thailand, moved to Minnesota when I was about 3 years old with my family. I've lived in Minnesota ever since. So culturally, I identify very much as Hmong American as well as Minnesotan. I also have 4 children. I live in North Minneapolis, and just dealing with COVID, dealing with all of these changes has been a huge eye-opener. Professionally, I am a health psychologist. And so I have been working in healthcare for about 7 years now. I started as a pre-doc intern, stayed on as a postdoctoral fellow, and I was lucky enough to have been hired on as a primary care behavioral health psychologist. So I worked in primary care settings and integrated team settings. But in my time at Hennepin, I was also a part of the psychology consult service. And what that service does is we are consulted by medical providers all throughout the hospital system when there's an urgent need. So maybe someone got into a motor collision and sustained a spinal cord injury. They might call the psychology consult service. We come in bedside to meet with patients and provide instant kind of in the moment coping skills. This may be for any other kind of conditions that come into the hospital. I tell you this because my experience within the healthcare system, whether in ambulatory outpatient settings or inpatient settings, has really informed me in terms of our healthcare system or systems, and the different ways that healthcare providers or the healthcare system may show up and impact a patient's care, especially when patients are from historically marginalized identities. So that's a little bit about me. By the end of this training, you should all be able to identify the process by which implicit bias is formed, explain how bias impacts health disparities, and again, apply evidence-based interventions to decreasing bias. I do have a disclaimer here I'm going to read. It says, it is important to recognize all marginalized identities are subjected to health disparities on some level, including but not limited to LGBTQ populations' ability status, migration, refugee status, or gender. However, for the purposes of this training today, I'm going to be focusing in on race. Keep in mind that these concepts are oftentimes generalizable to other marginalized populations as well. Let's jump into it then. What is bias? There's a belief that, or bias is the belief that there are just some people, some ideas, or some practices that are better than others. And this ideology oftentimes leads to differential treatment. So researchers believe that there's a distinction between explicit bias, right, or implicit bias. Now, explicit bias means that our bias, right, it exists within our conscious awareness. And so when we act on it, it is with intention. I'll give you an example. Let's say I go and I want to enjoy some really nice ice cream. I go to Ben & Jerry's. When I go to Ben & Jerry's, my favorite ice cream is Cherry Garcia, the best. Chunks of cherries, chunks of chocolate. I love it. So when I go into Ben & Jerry's, I am purposefully, intentionally selecting what I think is the best ice cream in the world. Explicit bias happens within our conscious awareness, and when we act on it, it is with intention. Now, implicit bias occurs outside of our conscious awareness. We're not necessarily aware that we have these biases. And so when we act on it, we may not be aware that we are acting on a bias. Scientists say that implicit bias can cause more harm than explicit bias. And the reason why that is because implicit bias, again, if people are not aware of these biases and it's occurring outside of their conscious awareness, they can continue to perpetrate. And they can continue to perpetuate systems of oppression that can actually hurt or harm others, even without intention. So we're going to be talking about implicit bias because of the potential impact that it can have on the patients that we serve and the people that we work for. Well-meaning providers who externally embraces anti-racist ideologies can still have racial implicit biases that favor white people over people of color. This is hard. This is hard because many people go into healthcare not because they want to hurt people. Many people go to into the healthcare industry because they want to help people. And so to know that all of the data suggests that even though people are explicitly saying, yes, I believe in anti-racist ideologies, they can still have these biases that bias white people over people of color. And this is impacting health disparities. So if we all hold implicit biases, how then are implicit attitudes formed? Because this is going to be important for us to know. In order for me to really talk about this, I want to talk a little bit about theory. Originally, when I designed this training, I had at least 3 theories that I would go over because I love theory, but I'm not going to bore you with all these theories. I'm only going to talk about one theory, and that is the information processing theory. So according to the information processing theory, our brains are like computers. Our brains have to be able to sift through all of this information that is coming at us, sift through it, organize it, and make sense of it. And so once our brain is able to really sift through this information, organize it, our brain has to also then store this information away so that when we encounter another situation that is similar enough, our brains can go back into that storage space and say, oh, I've been here before. This is what I've learned about this situation. This is how I'm going to show up. Our brains do this, just like computers. Now, when we think about racial interactions and the things that and our biases, it is believed that such cues like skin pigmentation or indicators of age, these are oftentimes primary categories for organizing information about other people. So our brains kind of take a look at people that we meet for the first time, and we start to try to draw similarities, right? That what we perceive to be similarities may not be similar in reality, but what we perceive to be similar with others that we may have encountered, and we group these things together. So our brains, again, do this for a reason. It's really just trying to make sense of things. Essentially, what we're doing is we're categorizing. We're categorizing to simplify the environment that we have to navigate day in and day out. We group characteristics we think people have in common to categorize. And eventually what we do is we create all of these filing cabinets of information, of data. And so again, when we meet somebody for the first time, or we encounter a new situation, our brains can go back into the filing cabinet and say, okay, what do I know about something similar to this? There's a clear function, right, to how our brain functions and how our brains do this. It's to help us. Now, let me give you an example. What am I talking about? What does this mean? When we as humans encounter a brand new situation and we're trying to learn a new skill, it takes a lot of cognitive effort, a lot of energy for us to learn these new skills. And so I have to really pay close attention to what it is I'm doing, and this can be really tiring. For example, when I first learned how to drive, I got to learn with my parents' Toyota Camry. I would take my parents' Toyota Camry, I would sit in the car, and I was really careful. I wanted to make sure that my mirrors were all in place. When I was driving the car, I couldn't even have the music on because I wanted to really make sure I had this right. And so when I would step on the accelerator or on the brakes, I wanted to make sure that the pressure of my foot was just right. By the time I got from point A to point B, I was tired. I was exhausted. Now with practice, right, I was able to perfect this. Now, I'm now able to drive from one point to another and back again and not even realize how in the world I got there. How did I get here? I didn't even remember turning on that street. That's because it's become so second nature. It no longer takes that amount of energy. It no longer takes that amount of effort. And now I have this schema. I understand how automobiles operate. I can now jump from that Toyota Camry, a sedan, to a van or a sports car or a boat or a motorcycle, and generally have the same framework for me to be able to drive different modes of transportation and not have to feel like I have to start all over again. That's an example of how our brains take in information, store it, and take it back out to use it when we need to use it. So our brains function in this way. And because of the functionality of our brains, it makes us more susceptible to collecting stereotypes and having bias. There's another concept called cognitive dissonance that I want to make sure that we talk about as we're talking about the brain. Cognitive dissonance is what happens to us when we receive new information and we don't know what to do with it. Say I receive new information and I don't have a filing cabinet created for this new information yet. What this new information does is it starts to create tension in my body, a sense of disequilibrium. And that's actually believed to be a way that our brains draw attention and say, Tali, you need to pay attention to this. We don't know where to store this. What are you going to do with this new information? And now I have to actually take the energy and time to sit with it and understand what this new information is, process it, and either I store it in a brand new filing cabinet or I expand another. Why is this important? This is important, especially in the context of implicit bias, because I find that sometimes as we are starting to understand or see an unconscious bias for the first time, a bias that starts to rise into our conscious awareness, it may cause cognitive dissonance. Let's say that I am somebody who highly, highly values social justice, anti-racism. And all of a sudden, I have this bias that is starting to rise into my conscious awareness that directly goes against that value, how I see myself. That's not going to sit well with me. That's going to make me feel unbalanced. And I need to sit there with that realization, with that bias that I've just come to recognize. I need to process that. I need to understand where that bias is coming from. As we are talking about cognitive dissonance or implicit bias, you may notice this sense of tension arise within yourself. You may notice this sense of disequilibrium. Pay attention to that. Should cognitive bias, should cognitive dissonance show up for you? Now, at this point, I would like for us to take a deeper dive. Because so far, we talked a little bit about what is bias. And we also talked a little bit about how we all have a bias. We all have several biases. But this is really just because of the ways that our brains work. Let's take a deeper dive. I want us to talk more about the context that informs the content of our biases. And in order for us to do this, let's talk about the history of racism. I want to start by talking about the history of racism and its difficult relationship with academic institutions. This is a difficult history that has not necessarily been grappled with, but we're going to talk about it because it matters. I'm going to talk more specifically about African American history as well. When we take a look at African American history and academic institutions, what we find is that some of our top tier universities in this nation are Ivy League schools like Harvard, Princeton, Yale, Columbia. These are schools or institutions that have produced scholars that have changed many aspects of this world. These Ivy League schools have produced scholars that have influenced the fields of medicine, technology, arts, literature. These are also the same academic institutions that have also produced scholars that have published in peer-reviewed journals, scientific peer-reviewed journals, on the superiority of the white race and the inferiority of Black and brown races. These institutions published research saying that Black bodies are built differently than white bodies, more able to engage in hard labor. These scholars produced research articles that said that the morality of whites are so much more advanced, or intellectual abilities. I want us to just take a moment to think about the impact of these types of narratives, not only in the United States, but globally. To really bring that point home, let me share with you an example. In 1997, Dr. Wakefield and colleagues published an article. This article connected the MMR vaccine to autism. Said, hey, MMR vaccine leads to autism. Everyone was up out of their seats, surprised. Researchers went out trying to replicate the study. Families decided to not vaccinate their children. There was a ripple effect, consequences to what this article was suggesting. By 2010, this article was retracted because no such evidence was found. Now, when this article was retracted, it was estimated that tens of thousands of people all around the world had refused the MMR vaccine. And we saw pockets of different illnesses that was once well controlled pop up. And even today, even with multiple other articles that said there's no truth behind this, it's unfounded, it's an unfounded claim. Even with all of this rebuttal of this research article, and medical providers and scientists coming out and saying there's no foundation to this claim, people are still believing this, but especially vulnerable communities are still taking this as truth. And we're seeing the impact on that. That's one article. That's a couple of decades, right? Not even that long. Let's go back now in history. When you have multiple scholars that are highly revered in the scientific world, that are publishing these so-called scientific journals, it's making these false claims, these statements. Imagine the insidiousness of that messaging. Again, that messaging of the inferiority of Black and brown races and superiority of white races. Imagine how that continues to creep into our fields of medicine, into our fields of studying arts, literature, legislation, our economy, because it does. There are detrimental impacts. Prior to the 1920s, North American and European social scientists nearly all agreed that whites were superior to people of color, but especially in the areas of morality, mental abilities, and physiology. We know why that is. This narrative wasn't born out of nowhere. It came from people. Now, this school of thought led to the eugenics movement. For those of you who may not be as familiar to the eugenics movement, this was a movement to try to improve the human race. And to do that, what people did was they really tried to encourage the reproduction of those with so-called good genes, and then to stop or discourage those with quote unquote bad genes, less desirable genes. So who were those that were seen as having good genes? Anybody who was white and Christian and heterosexual and cisgender and physically able and didn't have a serious mental illness. These are the people that were encouraged to reproduce. Everyone else, there were movements of genocide all over the world, and also movements to sterilize entire populations. Again, the outcomes of this type of thinking is detrimental, widespread impact. Let's pivot a little bit. Let's move away from the history of racism in our academic institutions towards the media. What's interesting is that research has shown us that what we choose to read, what we choose to watch directly has the ability to influence the content of our stereotypes. In one particular study, researchers wanted to take a look at this. And so what they did was they took on study participants and they gave them a pre-test and a post-test. So what the pre-test was the implicit attitudes test developed by Harvard University. There's several, right? Bias against same-sex couples, bias against race, bias against religion, bias against ability status. There's a whole list that you can choose from. These researchers chose to study bias against Muslims. And so what they did was they had participants take this bias test to kind of see where their implicit bias was at, and then exposed participants to news coverage of the US and Iraq war. Now, the news coverage of the US and Iraq war, of course, came from the US's perspective, not Iraq's perspective, right? And after watching a whole series of news coverage of the US and Iraq war, then participants were given the implicit attitudes test again at the end to kind of see if there's any changes in bias, implicit bias. These researchers found that after being exposed to the news coverage, bias against Muslims statistically significantly increased. We know that when that happens, it's not by chance. The impact of watching the news and that from that bias perspective directly influence the participants' bias pretty immediately. So researchers wanted to know if the media can have a negative impact on people's bias or stereotypes, then might the media also have a positive influence? So a different group of researchers wanted to investigate this, and they got a group of college students. And so what they did was they wanted to look at bias against same-sex couples. They have the group of college students. They give them the implicit attitude test, right, by Harvard, but this time focused on bias against same-sex couples. And then they showed these college participants this TV series called 6 Feet Under. For those of you who may not have watched the series 6 Feet Under, in the series, the main character is a gay man. And he is in a really wonderful, healthy relationship with his partner. The negative stereotypes of gay men did not make it into this TV series. Now, after watching this TV series, students took the IAT again against same-sex couples, and these researchers found that these students' bias, implicit bias against same-sex couples, statistically significantly decreased after watching this series. I think that this is really, really important information as we're thinking about our society today, not only about all of the media and the news that we are exposed to just because of all the different methods that we have at our hands, but also what we might be able to do with this knowledge. How can we use this knowledge to benefit us? Let's talk a little bit about visuals in media, because this also impacts our bias. This is an advertisement by Paris Soap from 1765. And in this advertisement, you'll see that there are two boys and two scenes. In the first scene, we have a white boy and a black boy. The black boy is taking a bath. The white boy is ready to drop a bar of soap into the bathtub. Second scene, the black boy is done taking a bath. And look, the soap was so effective, it washed the black off of the boy's body. What is this implying? Black is bad. Black is dirty. Look, our soap is so good, it washes the black off of you. It's horrible. But was it a sign of its times? This is an advertisement by Dove Soap from 2017. This advertisement was posted, it's a video reel, and they're in Facebook ads. I believe that some of this was also posted on billboards. And what you see here is a black woman about to use Dove product, and this Dove product apparently turns this black woman into a white woman. There was backlash from communities, but especially the Black community, to pull these advertisements off the shelf. Dove did issue a kind of generic apology. But what we know about history and what we know about the offenses that this nation has perpetrated against Black people, this goes so much deeper than just an innocent mistake. Let's take a look at this advertisement, again, by Dove Soap, where we have a Black woman standing in front of this before picture that demonstrates dry, ashy skin, and then a brown woman, which appears to be Latinx, in the middle, and then we have a white woman in the after photo with luscious, glowing skin. What is messaging like this potentially portraying? Or this bottle that says nourishing lotion for normal to dark skin. What abnormality is being implied? Now, some of you may be looking at these and you may be thinking, what in the world? How did these advertisements pass all of those lines of compliance and all of those before it was approved? How did it get approved? No one caught this? Some of you may be looking at these and thinking, you know, Dove is really trying to be inclusive. We can't attack them. And they're just trying to include lots of different women of color. They can learn from this. Regardless of what might be going through your mind right now, what I will say is implicit bias and the lack of awareness of history in this nation can lead to harm, even when the harm is unintended. Now, I'm not saying go out and stop using these products, go out and boycott these things. But what I am saying is we need to demand for accountability and we need to demand for a difference when these things show up. So with that, I want us to think a little bit about what we just learned so far. We learned about implicit, explicit bias. We learned about the ways that our brains work, how we organize information and how this can prime us for bias. We learned a little bit about history, the history in this nation that has influenced the context and the content of our bias, whether it be through schools, through the education system, whether it be through the media, the images that we are bombarded with every single day. And then I want us to think a little bit about the field that we're in, and that is healthcare. Some of you may be clinicians, some of you may not be clinicians, but I think this is an important point regardless. What makes a good clinician? Let's talk about this. A good clinician, because clinicians, they go to school for a long time. They go to school for a long time and then they go to maybe do their practicum, their clinicals, their internship, postdoc fellowships, right? Lots of different lines in place to ensure that people are coming out as good clinicians. People want to be good clinicians. So what makes a good clinician? A good clinician is someone who is able to take in a whole bunch of information, categorize information, sift through the information. That way, they can go back and retrieve the information in very efficient ways, but especially when it's high pressured, when the situation is urgent. They need to be able to go back into their filing cabinet and say, this looks like that situation, generate a hypothesis about what's going on in the patient right in front of me. What is the potential diagnosis? What is a treatment plan? Good clinicians learn how to do this fast, how to do this efficiently and effectively and correctly so that they can save lives. This sounds really similar to the information processing theory. So if we know, hey, information processing theory says that our brains do these things and it primes us for bias. And then we also know good clinicians do all these things so that they can be really good clinicians. Then aren't I saying that good clinicians, because they get really good at this, they're perfectly primed for bias? Yeah. So what am I asking? What am I asking for? It is incredibly, incredibly important that as people are engaging in their work as a clinician, that they are ensuring that they are a good clinician to every individual person in front of them. And so it's going to be important for us as good clinicians to pause and ask myself, am I making assumptions about this patient in front of me that may be impacting their healthcare? And if I am making assumptions, might I just clarify? Sounds easy. But the truth is, the more you're day in and day out in that position, we create routines. We create shortcuts. And not only do we create routines, right? This is somebody coming in with the cough. I'm going to do these. This is the labs I'm going to do. I'm going to ask these questions. But we also then are we're also vulnerable to institutional pressures. And so if we are feeling pretty exhausted, and if we're feeling like we don't have a lot of support, we're going to likely cut corners even more. Research shows us residents first coming into healthcare systems, they have much less bias. They produce better quality care than many of their preceptors who are teaching them. The belief is just that. People who've been in this field for so long may be jaded. They've kind of created their routine already. They don't want to deviate from that. We need to pay attention to what we're doing with our patients and ensuring that the care that we're providing matches the needs and the presentation of our patient in front of us. And sometimes it's just pausing, asking questions real quick. What can help us is if we can determine the factors that can activate bias. So if you think about this like a checklist, right, then think through this. If each of these factors come up and you can check it, then that means that the likelihood of having bias show up right now increases. And if I check all 4 points, then I need to be really, really careful because my bias is probably going to really show up in this case, and I need to check my biases. So what are these factors? Number one, pressure, time pressure, do more with less. Emotional pressure, and my goodness, are we all under emotional exhaustion, especially after the past 3 years, not only because of the pandemic and economic issues, but also because of racial injustices that are really coming to the forefront, though it has existed for centuries. Organizational pressure. Right now, the healthcare systems are really struggling, and I'm sure that all of us who work in healthcare, we're feeling the impact of organizational pressures as well. So again, if this was a checklist, each and every one of us should be able to check this off of our list right now. The second point is if we're missing information about the patient that is in front of us, we have to be mindful that our brains are likely to fill in the gap. Our brains doesn't like to work with gaps of knowledge. When we don't know something, our brains will oftentimes and effortlessly fill that in. And sometimes it is information from stories I've heard from friends, movies I've watched, right? Podcasts I've listened to, it just fills it in. I have to be careful. I'll give you an example. Let's pretend that the patient that I'm going to go work with is somebody who identifies as transgender. And let's pretend I haven't had much experience working with the transgender population. I need to be careful. My brain might fill in the gap. I have to be extra aware of potential biases. Unfamiliarity is another point that is important for us to keep in mind. Unfamiliarity gets at in-groups versus out-groups. So in groups, anybody that we see as similar to ourselves, we tend to like them better. This has been supported by research over and over again. There is such a thing as in-group favoritism. Now, this is also why people tend to hire others that look like them, give them opportunities if they look like them, right? And it can create a problem. And so if our patient that we're serving, the population that we're serving, we identify as an out-group, then we need to be very mindful. For example, when we think about tolerating who's late, who do we have more of a tolerance for if somebody is coming to meet with us 10, 15 minutes late? And who are we more likely to say, nope, that's it, I'm done, we're going to call this meeting? Oversaturation is a very important point that I wanted to make sure that we talk a little bit about. Now, oversaturation gets at this unique environment and high intense emotions kind of intersection. If you work in a space that is very unique and has high emotionality, you have to be very careful, because this is the perfect breeding ground for reinforcing stereotypes and biases. For example, let's pretend I work in the ED, and let's pretend I work in a safety net hospital, a level 1 trauma center. I work in an urban setting, and working in the ED, people are mostly coming in for injuries related to a violent crime. Now let's pretend that these people coming in for issues related to violent crime, stabbings, gunshot wounds are mostly young Black and brown boys. If I'm not careful, I'm going to start to believe that my environment, that my situation is generalizable, indicative of other young Black boys and brown boys. And that's not true. I'm going to say that again. It's not true. Working in that situation, I have to remind myself, this is an emergency department. Nobody comes in here when they're doing great, when they just got a promotion, when they just got into college. People are coming in here in their worst moments. I'm working in the emergency department. I'm working in this location. These are the types of cases coming in, not generalizable to the general public. I need to remind myself of this. Otherwise, again, we risk reinforcing stereotypes. So what does this have to do with health disparities? You may be able to guess already. I want to talk a little bit about that. And of course, I'm very sure that many of you are very aware of the social determinants of health. I'm not going to go into the different sectors, but what I am going to do is I'm going to focus in on healthcare and quality, because each of us has a hand in healthcare, which means we have the ability to start changing the environment that we work in. In 2002, the Institute of Medicine put out a report titled Unequal Treatment. It was one of the very first of its kind to produce a report that had comprehensive systematic evidence that actually showed health disparities are associated with the fact that people of color in this country receive unequal health care from well-meaning altruistic providers. Remember what I said about that's hard, this is hard. Again, these are providers that mean well, want to do well, good intent, and still are causing harm because of biases. In this report, they found people of color are less likely to receive appropriate medical treatment for cardiovascular disease, cancer, cerebrovascular disease, renal disease, HIV/AIDS, right? Asthma, diabetes, or pain. But also, people of color are more likely to receive inferior rehabilitative, maternal, pediatric, mental health, and other hospital-based medical services. Over and over and over again, I look at the research on cardiovascular disease, end-stage renal disease, on cancer, on mental health, psychiatry. All of these research show us that providers bring their negative preconceived beliefs about Black and Brown people's intelligence. Are they going to understand the difference between these 3 different treatments? Probably not. Let me just choose this one treatment and tell them all about it. Researchers bring their negative preconceived notions about Black and Brown people's disposition to engaging in risky behaviors. Thoughts that, oh, this person's probably an addict. Oh, this person probably engages in risky sexual behavior. Oh, this person probably engages in other criminal activity. These biases, these thoughts impact outcomes. Researchers found that providers bring their negative preconceived beliefs about Black and Brown people's likelihood of medical cooperativeness or adherence. Is this patient going to really be able to come in once a month? Probably not. So I have this medication that is really, really effective, but it requires that they come in once a month to get their blood drawn. So because I don't think they're going to come back, I'm going to give this slightly less effective medication, but only requires that they come in once every 3 months. These decisions that are made influences treatment recommendations, influences what is being scanned, what is being looked at, what the diagnosis is even. So with all of this, I think that I've made the case that our implicit biases can and does impact the decisions in the healthcare that's impacting vulnerable populations because they've been historically marginalized. Now, I want to talk a little bit about what can we do about this? What can you do about this? And so I offer empirically supported intervention to decreasing your own implicit bias, but we need to remember that this is a very personal journey. Decreasing your own bias is very personal. This is going to look different for everyone. First, it involves assessing for yourself, where am I at today? My conscious awareness of racism, my conscious awareness of ableism, whatever it may be, but for today, racism. Where do I want to end up? How much further do I need to grow? So ask yourself that as we go through these 3 different interventions that I want us to talk about. The first one, it's kind of obvious, right? It's your classic, acknowledge that you have a problem. We need to acknowledge that we all have biases instead of resisting this, just to know and to neutralize it and normalize it, right? We all have biases. Once we can acknowledge this, then we can make a concerted effort to raising awareness within ourselves to what our unconscious bias may be. What am I missing here? Why do I act like that? Why did I grab my purse? And stay curious. So that's the very first thing that we can do. Now, the second thing, research tells us that decreasing bias is highly effective if we expand our in-group. Intergroup contact. Expanding your in-group, meaning develop meaningful, long-term relationships with others that don't look like you, talk like you, have the same ideologies as you, different religions, different lifestyles, different cultural practices. Build deep, long-lasting relationships with others. And what this does is it starts to fill in the gaps of knowledge with real different types of knowledge and experiences. It dispels stereotypes, it dispels biases. And it creates the sense of in-group favoritism that can be a positive thing. Intergroup contact can be incredibly powerful and can be hard, but especially can be hard for people from the Midwest, for Minnesotans, where the saying is that in Minnesota, or at least this is what I've heard, in Minnesota, right, people are extremely friendly. They'll give you directions to everywhere else except for their house, because people are kind of, within their own groups or cliques. This means stepping out of your comfort zone and asking or inviting a friend that you work with to a family event. This means taking a risk and saying yes to an invitation if you do get an invitation to go out and to meet others and to build those relationships. What doesn't necessarily work is if the power differentials are too different. And what I mean by that is, let's, for example, say when my children were distance learning, it was incredibly, incredibly stressful. I had a second grader distance learning, and this was not a good idea. Let's pretend that in that hardship, I decide I'm going to hire a nanny to come into my home and help. And let's pretend that this nanny is not Asian. And I think this is the perfect opportunity for me to get to know this nanny who's not Asian. I can expand my intergroup contact. Perfect. This is not recommended. And the reason why is because the power differential actually can work against the very principle of what intergroup contact is trying to do. For example, if my nanny disciplines my children in a way that I don't agree with, if my nanny showed up late, if my nanny did anything that could potentially put on a thought in my head, oh, those people are just like that. This is it's not helpful. So keep that in mind. Intergroup contact, highly effective. There are some components that we want to be mindful about as well. The second intervention is indirect contact. Indirect contact is a little bit less effective than intergroup contact, right? That's because indirect contact is things like exposing yourself to media. We already know how potentially powerful the media can be. And so if we intentionally seek out media, right, podcasts, documentaries, movies that were created by and for people of the communities that we are wanting to really research and get to know better and understand better, we want to be very careful about that. But films and shows can help bring insight and empathy. And book clubs can be helpful as well. So book clubs, one of the reasons why that can be helpful is because if you're reading a really thought-provoking book, and like, for example, the book Cast, then to come back together to a group to discuss, critically reflect, and engage in that self-reflection with a group of people, that can really help propel you in terms of understanding and getting different perspectives as well. The third intervention that I want to talk about is this idea of habit extinction. As a psychologist, I focus a lot on behavior change. And so habit extinction gets at behavior change. Habit extinction at the heart of that is how, if I identify a behavior that I don't like and I want to change it, then I can implement strategies to start to change that behavior. Let me give you an example. Let's pretend that I smoke. And every time I get into my car to drive to work, I know that when I hit traffic, I have this urge to pick up this pack of cigarettes, pull out a cigarette, and smoke. but I don't want to smoke anymore. So that's the target behavior. So instead of carrying a pack of cigarettes, I carry a pack of gum. I take this pack of gum with me. I get in the car and then I sit in my car. And when I have this urge to take that cigarette out, I take a stick of gum out instead and I eat that stick of gum. I do this over and over and over again until that association, that habit starts to break. Then my behavior is ultimately changed. We can do the same thing when we identify racist behaviors or behaviors that we don't like that we are doing. We can change that as well. All right, so what does this look like? As a psychologist within the healthcare system, and especially the medical inpatient units, sometimes I get consulted to meet with patients bedside. I go in to meet with patients and I'm meeting with them in their room. There have been incidences where I go into a patient's room. This is a patient who is a brown patient and needs an interpreter. Other providers have walked into the room and said to me, "Oh, hey, you're the interpreter I've been waiting for." And I'll pause and I would say, "Actually, my name is Dr. Vang. I'm the psychologist who consulted." Sometimes they look horrified. They back out of the room, don't say anything, and walk away. Other times they may apologize profusely. "Oh my gosh, I'm so sorry. I can't believe I did that." This is an example of that behavior, that habit. Once identified, and if we feel horrible, we all do this. We all make mistakes. We all do or say something that we feel really embarrassed about or ashamed of. But it's that humility piece that gets us to actually saying, that's the behavior I need to change. So what you can do then, if you were that provider, when you walk into a room to see a patient and you know this is a patient who needs an interpreter, if you see another brown colleague, instead of assuming this is the interpreter, maybe introduce yourself first and then ask your fellow colleague to introduce themselves and their role here for the patient, and then engage in conversation from that perspective. So every time you see these cues, you can change your behaviors to start to change that unwanted behavior. So habit extinction is a really, really important cue or a strategy of intervention, but it does require humility and it requires a lot of attention in the beginning, mental effort. Catching yourself do things, right? That takes a lot of mental effort. Just like me first starting to learn how to drive the car until it becomes like second nature. And then we can identify a different habit that we want to extinct. So this is the third intervention I want to share with you all. And I am hopeful that you can take away some of these interventions to really start to decrease your own bias, however that might look like for yourself. With that, we are at the end of the hour. I am going to go ahead and stop sharing and would love to open this space up for questions or comments.
Thank you, Dr. Vang. What an excellent and powerful training. We received a few comments from participants of how great this webinar and information that has been presented. So thank you. Reminder to all that you can feel free to pose questions in the chat. One of the questions that came up around cognitive dissonance is, can cognitive dissonance cause moral injury / trauma? The participant was curious if the process of sorting out cognitive dissonance can cause moral injury, if the severity of internal conflict can leave an everlasting imprint on perception of the world involving that certain topic.
Can cognitive dissonance lead to moral injury or traumatic kind of inability to make sense of that? My initial reaction is cognitive dissonance can lead people to discovering traumas that they have encountered that is arising. Not necessarily traumatizing people, right? So for example, if I realize, I have this bias against, or let's talk about internalized racism. So for example, internalized racism is when you start to believe the lies that society tells you about yourself, especially if you're a person of color. Internalized racism, let's say I start to believe this, and then I have this cognitive dissonance, it's more likely that it's going to bring about, it may help me realize that there's been another incident, a trauma that has led me to try to protect myself by creating this stereotype and I would need to deal with that past trauma. But the likelihood of it being so severe that it's traumatizing is not very likely. Hopefully I answered the question.
Yeah, still seeing just lots of comments around a great webinar, very insightful. Don't see any particular questions yet, but everyone, participants, please feel free to put your questions in. Here is one. You talk about people of colors, POC skin color. Does hair color also impact this?
Hair color. No, because we're talking about we're talking about racism, right? And so racism is this ideology that there is white supremacy, meaning white is superior. And so that is very, very different from hair color, though I'm aware that there are some bias or prejudice against different people with different hair color, but that's a very different life experience navigating the world with someone with a different hair color, as opposed to someone being a race that have been historically marginalized by society and by people. Thank you for that question.
Here's another one that came in. What did you base your theories on besides your research? Were there any biases you found yourself having? Sorry, it's just scrolling up a little bit too fast for me. Were there any biases you found yourself having when choosing what you wanted to focus on?
So the theories that I focused on was really the theory of how our brains work. And so that can be applicable to many, many different types of historically marginalized populations. I chose to focus first on racism because we know that disparities, when you look at disparities, it is the most significant for different racial groups, but especially Black and Indigenous groups. And so by knowing this is where so when you talk about equity, right, it's taking resources and energy from and focusing it on where the greatest disparities exist. And that is exactly where it exists. It doesn't negate the importance of other identities that have been historically marginalized, like, for example, sexuality, sexual orientation, gender identity, or ability status. Doesn't take away from that. However, in terms of equity, that's where the highest need is right now.
Great. How can organizations address implicit bias in their work?
So this is a really great question, and it depends on the type of organization that you are in. And so I think that one of the ways is going to be some information. As the director of education of health equity education, I will have to say that education is not the answer. Education is a tool to help us get to the answer. But a part of this is not only informing and educating the entire organization, but to really take a look at practices, policies, from an equity lens. And so how do we start to actually implement this? How do we embed this into the work that we do, the structures of our organization, to start to incorporate some of the biases that we have? But it's a journey and it's a process for sure.
Are there suggested online resources that you would recommend?
Online research is in terms of health disparities, for sure. I think that you can definitely go into the database. There's state-to-state databases on health disparities, and then also even the World Health Organization or the CDC also have really, really great data on disparities. Now, in terms of bias, there's a lot of information out there. I typically like to rely more on sources that come from more of a scholarly kind of background where people are integrating a lot of the research. And so you may be able to find this from the American Psychological Association webpage, for example. That is something that I would recommend. Books, there's lots of books out there that are really great as well. I know that I mentioned the book Cast, but there are other books too that none come to mind right now, but I think that would be a rich source of information as well.
Great. Here's another question. So this participant is saying, when I meet people of different races, I find I am too cautious of my responses that might offend them. I find it difficult to be authentic and really get to know them. What are suggestions?
What I would suggest is don't take yourself too seriously. So, and I say that with the best intentions. And what I mean by that is this concept of humility. Trip over yourself, make mistakes. People are often very forgiving. And with that, when someone points out to you, right, well, what you said was actually offensive, take that feedback with grace and really perceive that feedback as a gift. And that can be hard. But even if it takes a moment or a day where you have to walk away and come back and say, thank you so much for that feedback. Help me understand how that was offensive so I can correct that. Oftentimes, again, people are very forgiving. And if we are avoiding interaction and beautiful relationships because we're afraid to make mistakes, then it's going to be a really, really sad life that we live, right? And what we see too, that I want to say is, with the pandemic, everybody social distancing, going back into kind of their homes. And then now that COVID is a little more controlled for, and it's becoming more normalized than it was when it first took off, what we were finding is that adolescents who really retreated back into their home are having a really hard time coming back out. More than just adolescents, adults too, but they're having a hard time coming out and socializing. And especially with technology, texting, social media, having just live conversations is starting to create some anxiety. They don't want to make a mistake. They don't want to look stupid. And again, the suggestion is the more we do it, the more exposure we have, the better we get, and the serious we take ourselves.
A participant is wondering, what are some of the things that Hennepin Healthcare is doing for providers or as a system in terms of implicit bias or racism? What successes have you experienced and what challenges still remain?
Hennepin Healthcare is doing a lot of different things, and some of these strategies are short-term and all working towards long-term strategies. So we have long-term strategies as well. Some of the things that we are doing at Hennepin Healthcare, so the Compass program is something that I've developed. It is a year-long intensive training program that builds in trainings just like this one, builds in trainings that helps people understand what implicit biases exist, but also builds in the history of racism that many different marginalized races have experienced in this country, to kind of fill in the context to inform everyone in our organization. So one of the things that our organization has done, our executive leadership team has agreed to have every single employee be trained in this training, so that when we talk about health equity, everybody will be on the same page. We'll understand, what do you mean by that? What is DEI, diversity, equity, inclusion? What does that mean here at Hennepin Healthcare? Why are we prioritizing health equity? So that we all have a standardized understanding of what this work is, why we're doing this work. And so that's one of the things that we're doing. We also have launched passed a policy. It's a brand new policy. It's called an anti-racism policy. In this policy, it says that our organization will not tolerate, will not comply with racist requests from our patients. For example, if a white patient comes in and says, I won't work with that Asian provider because that Asian provider has the China virus, our organization says that we do not have to accommodate that. Actually, that patient could go anywhere else to receive their care, where the institution is going to back up the provider. And that's huge, because that has never been the case before. And so there's different policies that are being enacted in different ways. So these are some of the wins. There are still initiatives that we're continuing to build, continuing to really create. Hardships, it's been hard, right? You're trying to undo systems that have operated in these ways forever. We are trying to become an anti-racist institution. That is something that we have never been. Being something that we've never been means that we're going to come across different barriers, and that can look different in different ways. However, what I find is that we have allies in many different corners. We have allies in many different spaces where we can really strategically come together and help each other out.
Thank you. Another question: how do I focus on my own racism which I understand is important to begin with. How do I really see my own racism?
I think by catching yourself when you feel uncomfortable. So, for example, when engaging in conversations on race, do you kind of recoil back? Do you hold yourself back? When you are hearing and listening to other people make comments and it doesn't sit right with you, how do you react? And so I would say start with really a deep curiosity. Ask yourself questions about why you do the things that you do, and that's really the awareness part first. And once you become aware of these things, find some trusted people in your life. Find some trusted people to go back and kind of reflect on these things with, to help you along. And this can be a coach, this can be a therapist, this can be other friends that you know have been doing this work, have been doing their own anti-racist work for a while. Do that and seek that out. I do think it can be helpful to seek out book clubs that are engaging in these conversations. For example, Hennepin Healthcare, our library holds a diversity, equity, inclusion book club meeting every single month. There are these wonderful books that they will read, come back together and discuss. Join book clubs like that where you can come in and start to kind of to talk about this. I was reading this book about systemic racism in housing practices, and I realized that XYZ, I don't know what to make of this. You can have this space to have that conversation because then others have also been reading the same or similar content.
Another question, can you speak to the difference between implicit bias from a negative sense compared to making assumptions from a protective factor? For example, walking at night and feeling on edge.
Yes, I would say be careful. And why I say be careful is because of this. We definitely need to make sure that we are safe. Our alarms in our brains do go off when we're in situations that can start to alert us to potential threat. However, if you notice that you're walking alone at night in a neighborhood where it's mostly white and you feel perfectly safe, and if you're walking alone in a neighborhood that it's predominantly black and you feel really, really scared and intense, be curious about that. Why is that? If you are making a stop at the stop sign and you see a group of younger white guys outside just hanging out, do you even have the thought of, I'm going to lock my door because I don't know what's going to happen? But if you do, when that group of younger guys are black or brown guys, and then you feel the urge to lock the door, ask yourself about that. Sometimes we may have encountered, and this word might sound strong, but I'm going to use it anyways. Sometimes we may have encountered traumas in our life. And if the protective factor is to say, anybody that looks like this, like this perpetrator, I'm going to be afraid of, my suggestion is there is a need to address the trauma, because that generalization is not effective and that generalization is potentially harmful. So hopefully that answers the question, and hopefully that makes sense.
There's a question going back to kind of articles. Is there any way to filter articles that may have race biases or stereotypes? How can I make sure my scholarly article is not based on this narrative and wanting to trust evidence-based data?
I think that this is a process. This is the way that I'm understanding the questions coming from more of a researcher perspective and somebody who is perhaps writing articles. This is a process that is going to be really important for that the writer or the researcher to really take a look at equitable language. And there are articles out there and guidelines out there. For example, the American Psychological Association has put out guidelines for writing research articles that are coming from more of an equitable lens. That could be incredibly helpful to see what is being recommended. I know that scientific racism is something that exists, and that is perhaps the misinterpretation of data to have more of that racial bias that's built into that. I think it's really just being able to go back and ask others who are in this work, researchers, scholars who are in this work, to help, right? To help kind of vet and check. It's kind of like having somebody edit your manuscript, perhaps. And so that's one of my recommendations.
Great. One more question that came in. So your example of autism and the MMR vaccine highlights a trend that expanded during the pandemic. Um, the idea that anyone's beliefs about health are as valid as that of scientists who have studied particular conditions or diseases for years. Can you comment on the tension between science and belief and how, other than with patients and acceptance, workers charged with protecting public health can be successful in this environment?
The way that I think about that is it goes back to this idea in this nation that politics is a taboo topic. This nation, our society, we don't like to talk about politics. It's something that should not be addressed at the dinner table. It's something that should not come into the workplace. And so this taboo of not talking about politics makes it possible for any issue to be weaponized as soon as it's politicized. And so I believe that the tension really comes from this tool of weaponization. There are people who are invested in really being divisive. And so I think that what is at the heart of this is we have to resist this politicizing of these topics that are not necessarily political. And to resist that, we have to continue to be able to talk about it and to really be able to continue to educate on that. So a part of it is recognizing that this is a tool being used against all of us as the public, that it makes us afraid to talk about these things and makes it feel so polarized, and to try to work to resist that by continuing to bring it together and really talking about common ground.
Another question. What are some tips on how to approach self-care when you experience repeated microaggressions in the professional world?
I would say if your organization has employee resource groups, ERGs, or at Hennepin Healthcare, what we call them are collectives, join a collective, join an ERG, join one that has affinity with different identities that you may have. So I know at Hennepin Healthcare, there are ERGs for different racial ethnicities, different professions. And then, for example, nurses of color or physicians of color or LGBTQ status. And we also have different affinity groups for and someone who may identify as Muslim, and so, or with ability status. These are great opportunities for you to spend time with others who are maybe experiencing similar experiences as yourself, to be able to come together and say, these are the things that need to change, and be able to have that direct line to leadership to say that these are the experiences. So I think that joining something like an ERG or the collective serves multiple purposes, multiple roles. Support system for one, being able to reach across systems to find others that may be going through similar experiences, but also to be able to be connected to a potential way of addressing issues if you so wish. That can be incredibly helpful. Taking time away. So when you are, let's say, you get off work and you still have projects to deal with, take a good chunk of time and just to mentally disengage. Spend time with your pets, spend time with your loved ones, spend time gardening, weather's still nice right now, whatever it may be. That type of self-care, you can't underestimate how far that'll go.
Great. Another question that just came in through the chat. How can I bring about to my leadership team about making our department more equity and diversity aware?
Can you repeat that, Gal?
Yep. How can I bring about to my leadership team about making our department more equity and diversity aware?
I would say it depends on where your leadership team is at in terms of their recognition of the importance of equity and diversity and inclusion. And if the leadership is not really on board, I think that the work kind of starts there. While some of the grassroots efforts are happening, I think, both grassroots efforts and then also really trying to manage up. These strategies of managing up can be incredibly, incredibly helpful. If the leadership team is on board, really being able to offer, for example, implicit bias trainings, or a group that can come in. Perhaps it's a health equity group or people in culture group that are trained in this work to come in and to really facilitate this work. So I think it's really being able to develop strategy instead of one-off trainings or sessions. It's strategy so that this work can be sustainable as much as possible.
Great. I don't see any additional comments coming in through the chat. I'm going to quickly share my screen just to say thank you again to Dr. Vang for such a great and powerful presentation. Also, thank you to all of our participants for your time today. You can fill out the evaluation. I believe it will be in the chat or the link will be in there shortly. Please take a few minutes to fill that out. Your responses are greatly appreciated. Upon completion of the evaluation, you will get the certificate of participation. And then recording, I know there were some questions in the chat around when this will be available. It will be available. The recording will be available in about a week, and it will be found on the Performance Improvement Project Diabetes page on the Stratus Health website. You will also be given a handout of evidence-based strategies to decrease bias instead of the actual slide deck that will be sent out. And so with that, I think we're good to go. Thank you all again and enjoy the rest of your day.